Good afternoon. I am Nikki Boyd with Sachs Healthcare, and I will be your technical producer for today's webinar. I also want to show our audience how you can send in questions throughout the webinar. Our speakers will try to answer as many at the end of the presentation. Before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded, and an online archive of today's event will be available soon after the session. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. Our speaker will try to answer as many at the end of the presentation. If you experience technical difficulties, please use the Tech Support tab also located on the right-hand side of your screen. If you are having trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen if you're using a PC or Command-R if you're using a Mac. I would like to introduce our moderator, Angela Craig. Ms. Craig is the Critical Care Clinical Nurse Specialist for the ICU at Cookeville Regional Medical Center in Cookeville, Tennessee. She is also the Sepsis Coordinator for her hospital and is on the Sepsis Coordinator Advisory Committee for Sepsis Alliance. Ms. Craig has lectured extensively at numerous conferences and webinars on sepsis and hemodynamic topics. She has also published the topics of sepsis and heart failure.
Thank you, Nikki, for that kind introduction. The title of our webinar today is The Deadly Deterioration, Surveilling Sepsis and COVID-19. And speaking on this very timely topic is my friend and colleague, Barbara Mclean. Barbara is currently an evidence-based practice clinical specialist for the Grady Health Systems in Atlanta, Georgia. She is a member of many professional organizations, including the American Association of Critical Care Nurses and the Society of Critical Care Medicine. She is the recipient of the Excellence in Education Award and Circle of Excellence for Clinical Practice from the AACN. She has written 24 chapters, 22 articles, and is a regular reviewer for Critical Care Medicine, Intensive Care Medicine, and New England Journal of Medicine. She has provided over 3,500 programs worldwide on hemodynamics, sepsis, and COVID-19, and took care of the first patient with COVID at her hospital in February of 2020. She is also voted the most valuable player for commitments to reducing sepsis at Grady Health Systems, and is a clinical advisor for the Sepsis Alliance Sepsis Coordinator Network Advisory. I wonder when she has time to sleep. She is so amazing. Our speaker has disclosed the following, and this activity has been accredited and approved for continuing education for nurses and respiratory therapists. This educational activity is approved for 1 contact hour for nurses and RTs, and you can see the accreditation statement below. Support for this educational activity has been provided by Philips. We would like to thank Philips for that. And at this time, I would like to turn the presentation over to our speaker and my friend and colleague, Barbara Mclean.
Thank you so much, Angela. It's such a pleasure to work with you, and I'm really grateful for this opportunity sponsored by Philips and for all the people at Sachs Communications for making this happen. It's such an incredibly important topic, and I've been fortunately unfortunate in actually being very much at the front line of COVID-19 as it's been rearing its ugly head. And let's just be sure we appreciate it ain't over yet. So I think this is really timely. Originally, I thought, oh, everybody's over COVID. We're all good. Oh, that's not true. So I think in terms of that, it does make it quite a bit more timely. Now, there are so many things to discuss, and our time is really, really short. So I'm really trying to focus on some particular aspects of COVID-19 and for really appreciating that there are some significant aspects of discussion that we want to uncover here about how do we define a predictive profile? How do we develop a predictive profile, an all-encompassing laboratory profile, methodologies to help us to understand decompensation? And I think we've been there, done that. We've been doing it forever with sepsis. We're still finalizing that. There'll be some changes, of course, with the new guidelines. But I think it's really important to integrate the role of information technology and to look at human factors as they relate to the predictive science of deterioration, and also to try to identify some strategies that you can do today in your clinical practice to help define what you're trying to do, and how you're going to encourage your patients, and always making certain that we're moving forward and really encompassing our patients with the best strategy that we have today. What we use today, and we've learned this in COVID, we also learned it in sepsis, and it's going to continue on. What we do today probably is going to change tomorrow. And of course, nowhere are people more fluid than in critical care and emergency services. So, to begin, we really want to think about COVID-19 and the origination of COVID-19 and understanding the aspect of COVID-19, especially as it was first enumerated. We first saw patients, what we thought about in the early stages of COVID-19 as it related to sepsis. So as we all know, in the beginning, COVID-19, as we all understood and all appreciated that it was a virus, but the early presentation was very much correlated to presentation of sepsis. So initially, some of the discussion was COVID-19 is viral sepsis. We're going to treat patients like we treat them with sepsis. We're going to do fluid resuscitation, antibiotics, draw blood cultures, draw labs, try to prevent them from de-evolving. Oh, now they've got pulmonary dysfunction. We're going to treat them like traditional ARDS. But as time went by, as we all know, any of us who are working with COVID patients, that started to change. So at first, the discussion was the correlation and really the similarities between COVID-19 and sepsis. And there are many. And thank goodness we have developed ourselves in terms of sepsis, because that certainly helped us with COVID-19. So just as a reminder, in the beginning, COVID-19 was initially considered to be a community-acquired pneumonia that evolved into ARDS. It was evaluated and treated as ARDS, and it was treated like sepsis, using a sepsis SBAR, using sepsis identification, using sepsis tools. But as we evolved into higher levels of understanding, I think there are two really, really important components of the evolution and understanding of COVID-19. So first, actually probably three, and there's probably way more than that, but for the context of this talk, first and foremost was the thrombotic endotheliopathy that evolved in patients with COVID-19. Now that's different than the microvascular coagulopathy that you might talk about with the evolution to DIC early on in sepsis. This thrombotic endotheliopathy evolved out of what we believe to be more related to hyperinflammation with immune suppression and activation of the RAS system. That is the renin-angiotensin-aldosterone system, which actually, as we go forward, appears to play a major role in the evolution of COVID-19. So very, very significant similarities to sepsis and septic shock, but the dissimilarities are really important for us to appreciate. So just a very basic, believe me, not the total shebang, not the total kebab, just a basic comparison between COVID and sepsis in terms of similarities and dissimilarities. Both have profound, overwhelming hyperinflammation. But in COVID and severe COVID, the bigger concerns and what folks are looking at now in terms of therapeutic interventions and evolving therapies are really about immunosuppression. In severe COVID, it's really immunosuppression. The similarities are arterial hypovolemia, multi-organ dysfunction, evolving to multi-organ failure. But what COVID taught us is aggressive volume resuscitation made matters so profoundly worse. And part of that is because of the accelerated disruption of the endothelial barrier that's known as the glycocalyx. And what we discovered in COVID was instead of aggressive volume resuscitation from the get-go, it was euvolemia all the time. Coagulopathy, similarity, but the dissimilarity is that in COVID, it was much more larger thrombus evolving as VTE, DVT, VTE, and also very significant and profound arterial thrombosis, less fibrinolysis, and more clotting. And that really relates to DIC, which is similar in both groups. But really in sepsis, it's systemic hypercoagulation, and in COVID, it's more related to local thrombus formation. Again, similarities, bilirubin, hypoxia, reduced glomerular filtration rate, and reduction in albumin. And again, remember, if I was doing just a comparative analysis and all the evaluations, that would be the whole talk. So it is really important for us to appreciate that there is a lot of similarity, but our therapeutic interventions are going to be dissimilar because the evolution is dissimilar. Now, sepsis is not a risk factor for COVID, but COVID puts our patients at risk for sepsis. So that's one of the reasons we have to always consider the intertwining of these two disorders. Now, very, very important for us to just reflect on something really basic. And I'm sorry, because I'm sure it's way too basic for the majority of you, but just to remind ourselves that in COVID-19, typically evolution to moderate and then to severe disease is primarily heralded, trumpeted by respiratory processes. And there are two respiratory processes that we always have to consider in COVID-19 as well as in sepsis. First is the internal respiratory process, which is reflective of the metabolism of gas and the carbon chain molecules at the cellular level, which is actually affected by the delivery of blood flow, the intact endothelial barrier, oxygen utilization, CO2 production, and excess acid production, particularly in the form of hydrogen ion made aggressively in the presence of anaerobic or hypoxic metabolism. Lots of other reasons that you have dysmetabolism, but in this case, that's what we're looking at. And then external respiration, which is the alveolar gas exchange, reminding ourselves that at the integrated alveolar capillary level, we have exchange of gas, we eliminate CO2, we promote oxygenation, and that all depends on A, alveolar recruitment, and B, appropriate pulmonary perfusion. So both of these processes, as we know, get significantly and profoundly interrupted in patients with sepsis and COVID-19 who progress into ARDS. But our goal here is to really look at those two respiratory predictors and find a way to integrate them into our profiles to actually predict and evaluate patients as they decompensate. So the internal respiratory predictor is the partial pressure of carbon dioxide in the venous blood, your end-tidal CO2, your base deficit or decreasing serum bicarb, and your lactic acid levels. External respiratory predictors, so straightforward, really requires so that we know what we're doing and we do it the right way, monitoring our respiratory rate, our pulse oximetry and SaO2, the PaO2, and the PaCO2 indirectly reflected by end-tidal CO2. So you can see where I'm going here. First and foremost, for external predictive models, two of the most important components that we can easily adapt in evaluation is the respiratory rate and the SpO2. We have to do labs to investigate these others, but from the very front line, we can evaluate progressive changes in respiratory rate and progressive changes in pulse oximetry to try to predict what patients are going to deteriorate. So we just think about looking at our lungs, and in this visual, you'll see that we have some pleural densities, and we also have a little bit of what we call the ground glass phenomenon. But reminding ourselves in terms of first sign of deterioration, from mild to moderate, where patients may or may not be short of breath. They typically will have some rapid shallow breathing. They might have a lot of coughing. They have a little bit of a struggle in completing sentences, and they use accessory muscles to breathe. Now, they're not typically describing themselves as being completely short of breath, but from the observer's point of view, you actually would see that as shortness of breath. And on the first patient that I saw who was admitted to us on February 28th, who, by the way, was a 26-year-old man, he could barely complete a sentence. He was breathing so fast. He didn't feel that he was having difficulty in breathing, but his progressive respiratory rate went from 35 to 45, almost up to 50, and his saturation started to drop. So in early deterioration, we know that extreme tachypnea and limited hypoxia can be very meaningful. There may be some right heart complications, some venous engorgement, and some reduction in right ventricular ejection, pulmonary perfusion, but also really important to remember in the early stages here of decompensation, in general, the alveoli are recruited, the lungs are compliant. And then we move to later deterioration, which is extreme hypoxia. So going from mild hypoxia to extreme hypoxia, and to loss of lung compliance and indices of right ventricular dysfunction or right heart failure, gaining weight, fluid overload in the venous compartment, reduced volume load in the arterial bed, renal dysfunction, and on and on. So we want to think about how do we maximize this evaluation along with laboratory analysis to actually have a prediction at the bedside of patients who are at risk. So this is a lovely, lovely visual, and it's very complex. And you know what? That's because COVID is complex. We can't make it simple just because we want to. I want to. I'm struggling every day to read all the literature and stay up with the evolution of the science. But pretty straightforward is the inhalation of the virus, which then causes a very significant degradation of the lung, stimulates your inflammatory response, which is mediated by neutrophils and monocytes and macrophages, and those actually promote the response of the cytokine. The cytokine storm stimulates the ROS system. It causes cellular dysfunction in all of our organs and ultimately stimulates microcoagulation. So as we look at the complexity of this evolution and also the desire of all of us to understand this better, we always go back to considering what's happening in the lungs. And so here you have a beautiful view of the lungs with a ground glass visualization. But typically for most of us in a standard chest x-ray, what we just see is diffuse opacities. It's really in the lung CT where we start to see the ground glass appearance. That's very helpful for us in terms of evaluation of our patient. And of course, you have other visuals here. These are all from a very sick patient with COVID, but our focus today is really talking about the early signs of dysfunction, which are primarily related to the lungs and the state of the lungs. So initiation is the replication of the virus and then viral-induced damage. So a big manifestation of the immune response, and in particular today, which might be different than tomorrow, we believe particularly related to tumor necrosis factor alpha and IL-6. Now, if you're in a big center that does research, you have a really stable, well-developed lab, you can look at these levels in your laboratory profile, and they are predictive of patients who are evolving and decompensating. For most of us, though, we're just thinking about basic evaluation, CBC with death. We might not be looking at these particular pro-immune and cytokine responses, but very important to remember that they actually cause the dysregulation also of the renin-angiotensin-aldosterone system, and in the end, that causes very significant, profound vascular permeability changes. So the state of the lungs is really, really important. Now, the first person who really talked about the state of the lungs was John Marini and Luciano Gattinoni. And Gattinoni and Marini put forward a basic editorial that then evolved into an article that really looked at the difference in the two lung states of patients. That the early patient had low elastance and high competence. They merely required, not merely, but they required a much higher FiO2, but they didn't really need alveolar recruitment because the lung was compliant and functional. And that in those early stages, when we all began, we were intubating these patients quickly and doing kind of recruitment strategies and discovering that that actually made the patient worse. So over the first 2 or 3 months, so by May of 2020, we were saying these are patients who really need high flow oxygen. We'll self-prone them. We'll prone them if they need it. We're going to do very aggressive pulmonary hygiene. The patients had compliant lungs but required very high FiO2s, and that was really profoundly important. And there weren't any steroid recommendations at that time, and one of the most common issues was their effervescent temperature. Now, what does that mean? What I discovered that meant was, as long as I put my patients on fever control that was on the clock, my patients did all right. But if I didn't control their temperature, I didn't have cooling blankets, I wasn't changing Tylenol and Motrin and Tylenol and Motrin so that my patient was getting something every 3 hours or so, I was actually discovering that I wasn't really able to manage the patient's temperature, which was really concerning for me. That evolved into our classic ARDS perspective. So ask the ARDS perspective that now the lung is very distended, has high elastance but very low compliance. And those patients needed higher PEEP. They had to be on low tidal volumes. They were typical ARDS patients. We needed to control their FiO2, and they rapidly progressed to microvascular pathologies. So despite excellent ventilatory support, the microvasculature changes that were occurring as these patients moved from mild to moderate to severe, that we were unable to really overcome that microvascular dysfunction. And so what we really were doing with those patients early on was we would put them into manual prone or rotoprone. We were using high PEEPs. Our standard starting PEEP was 12. Our max PEEP was around 22, and quickly moving, if possible, to VV ECMO. And this was the time that we were considering in our institution. I think the science certainly supported it in the beginning. The administration of Decadron early or any corticosteroid early on to actually control inflammation and to promote some immune suppression. Okay, so big deal is I would rather you recognize me on the left-hand column when I was hypoxemic, some vascular dysfunctionality, but when my alveoli are still recruitable and my requirement was higher FiO2 rather than something else. And that was always a happy thing for us, to try to treat patients early and prevent them from the evolution to that classic ARDS type. The other thing that we saw, and I'm sure all of you saw, is that secondarily we had a very high incidence of acute kidney injury. So we had significant and profound renal hypoperfusion. We had very significant renal hypoxia, destruction of the renal tubules and the podocytes of the kidney. And in the beginning, again, we really looked at that as a secondary consequence of cytokine overproduction, sepsis and cytokine storm. Remember the microvascular coagulopathy, and that was also occurring in the arteries and veins as large thrombi, not just microvascular. And again, in the beginning, always thinking about hypo and hypervolemia and trying to find the perfect spot for euvolemia. If we gave too much volume, we had renal congestion, abdominal hypertension, and renal compression. If we didn't give enough volume, we didn't have adequate renal perfusion. But again, I want to come back to the renin-angiotensin-aldosterone stimulation and the binding of the virus to the angiotensin-converting enzyme receptor sites, which actually has been linked to direct injury of the vessels. Again, our discovery was to reiterate again and again and again to limit fluid resuscitation. It became very difficult to sort of differentiate the cause and the effect of resuscitation and the virus and what else was occurring, whether we were using balanced versus unbalanced fluids, balanced being lactated ringers and plasmolyte, and unbalanced being normal saline, and reminding ourselves about the similarity of AKI and sepsis and AKI and multi-organ dysfunction, but also the word that came up time and time and time again, which became much more important, and that was the endothelial barrier known as the glycocalyx, and that the destruction of the glycocalyx, first from the virus and second from over-distension of the vessel wall, is considered to be very significantly important in the evolution of kidney injury and kidney dysfunction requiring CRT. So we really tried to develop fluid resuscitation strategies by individual endpoints, most particularly for me, looking at stroke volume and stroke volume responsiveness. And also, we actually started to integrate renal replacement therapy earlier when patients had refractory metabolic acidosis. Remember that internal respiration failure. So the other thing that was really important is to remind ourselves that all the time we don't really want to actually be going in and out of the room frequently, but that the incidental hyperglycemia that we saw in COVID-19 patients increased mortality 7-fold. So management of hyperglycemia, most particularly with the continuous IV insulin protocol, many centers, Montefiore being one of the most important ones, developing methodologies for sliding scale long-acting insulin, but actually discovering that continuous IV insulin managed the patients more effectively and more appropriately. And I come to the end of this little segment just to remind you that today, we have lots of concerns that this is an angiotensin-converting enzyme 2 receptor issue that actually strategizes and works in concert with direct viral injury and causing endothelial dysfunction, microcoagulopathy. And these right now, so the RAS system and the ACE2 receptors are of the highest suspicion, invaded by lymphocytes, pro-inflammatory cytokines, hypercoagulopathies, and this microangiopathy, this destruction of the endothelium and the microvessels, the microcoagulation, all part of our bigger concern, but we aren't certain about what's going to come next. So it really is a very important perspective to remember that much of this requires a laboratory profile that is adequate. That helps us to assist evaluation and intervention, to stage where the patient is, and our profile should consist of hyperinflammatory measures, immunosuppression measures, hypercoagulation measures, and internal and external respiratory measures. There's no way around it. You've got to have good laboratory evaluation. This beautiful visual that was taken from Lancet, which is an article that discusses white counts and coagulation measures, you can see that two of the most important ones are IL-6, which you can see significantly increases and progresses in the upwards level in the non-survivors of COVID, as well as an increase in serum ferritin. But you can see early on, when you start to see that increase, you might have to be adjusting your therapeutic intervention and plugging that profile into your clinical presentations that you're using to tell you that you have a patient at risk. So this is not all of the abnormal labs. Very, very important. We certainly see D-dimers profoundly increasing, just like we do in sepsis. We see lymphocytes The lymphocyte is a really big one here because the lymphocyte count, so hyperinflammation going up in survivors, but the immune suppression is what is really critical here, because you see in the non-survivors of COVID-19, they have immunosuppression. So that's where we are right now. Hyperinflammation plus immunosuppression actually are primary dictators. So again, we go back to this little list, and I want to remind you the most important strategy that we look at the bedside is the evolution of hypoxia and a change in your respiratory rate. At the bedside, without the lab, that's going to be one of the major factors that we're going to use to talk about our patients. Okay, so now, innovation and monitoring. We all did innovation and monitoring during our surge times, and some of those innovations and monitoring we have kept on board as part of our monitoring perspective. So I'm going to just show you a few of the innovations and monitoring that we had in my institution. First, we use an electronic glycemic management system, and second, we deployed our patients' continuous blood glucose utilizing Dexcom that was with an EUA. It's not approved for in-hospital utilization, but the Dexcom measures of the patient's glucose were displayed to a iPhone that was in the wall of the patient's room that allowed us to monitor their continuous blood glucose and adjust insulin on a pump outside of the room to get our patients safely to target glucose without incidental hypoglycemia. The second thing that we took, and here's the Dexcom. Sorry, it's so small I couldn't see it very well. Here's my Dexcom in the wall. It's in a sleeve in the wall of the room, projecting the continuous blood glucose monitoring. But here's the other aspect here. We used digital urinometer with positive airflow, so urine was always flowing, never trapped. We never had to go in the room to milk the Foley catheter. We used a particular device. There's a lot on the market, but the device we used was the Acute device, and we were the first hospital in the world to actually display digital urine collection outside the room to an iPad that was mounted on a pole. So instead of going into the room to empty the Foley, to milk the Foley tubes, we were doing continuous collection of the urine output. We're also able to measure intra-abdominal blood pressure as a continuous methodology without nurses entering the room. We could measure it from outside of the room. So I know we all had lots of innovations in our monitoring. The other aspect would be innovation predicting mortality, which is also necessary. And there's so much data about artificial learning and methodologies using clinical predictive models for mortality, innovation predicting mortality, which helps us to appreciate that we want to be able to look at those patients who have a higher possibility of survival. Then we think about predicting the progress of the disease. Again, that looks at mortality, and it looks at machine-based learning and artificial intelligence, which helps us move forward towards methodologies for evaluation of patients. So this is a beautiful improvement project using artificial intelligence and they radiograph 4,000 x-rays of patients with COVID, and then actually developing strategies that helped to actually promote and predict what patients were going to deteriorate during COVID-19. So I just want to show you their strategy. Again, like COVID-19 itself, like sepsis itself, although COVID-19 much more than sepsis, very complex. But looking at risk scores based on attributes of these almost 4,000 chest x-rays, oh my gosh, such an amazing tool. So for our future, and I would say developing soon, that we will see models for artificial intelligence as prediction models that help us in the future. But also, I'm going to just mention predication sounds really good, and that actually is right. But really, it's protection and predication necessary for us at the bedside to understand the prediction model of patients and to protect patients as they move forward in COVID-19. So innovation and protection prediction is very necessary. And what we think about is that as patients are decompensating, and remind ourselves in COVID that this is not a heterogeneous, or it's not a homogeneous process, it's a heterogeneous process. They all don't do it in the same way, and the patients themselves are complex. The disease is so complex, and we're still trying to understand it. And then our healthcare systems are complex. They're inherently complex. So we have to consider how we bring this forward and how we also integrate and understand that goals of therapy might be different tomorrow than they are today, but that we need early warning systems. So some of you who know me know that I really believe in early warning systems. In my hospital, we have a manipulated Muse. It's probably really is a Buse, Barbara early warning system, or what we're calling is M2 Square early warning system, the development ultimately of Mclean Mady Square, looking at an early warning system. Most early warning systems are based on clinical concepts that we evaluate at the bedside, and those early warning systems may miss the single most important factor of decompensation, particularly in COVID-19, or the two most important would be respiratory insufficiency and evolving hypoxia. Because we're not measuring patients continuously, and because overall we are not so great at monitoring respiratory rate. So we certainly know that Muse or News is just not adequate for actually predicting deterioration in specific disease states. Muse and News are developed to tell you about generalized prediction models of deterioration. But what if we could create prediction models that were particular to our patient's deterioration state, and in particular relating that to COVID-19 and focusing on the top two and then the third. The top two being respiratory rate and hypoxia, the third being end-tidal CO2, and the fourth being temperature. So let's think about how do we develop those prediction models and how do we apply them at the bedside, because we could do better if we had more specific programming where we could develop alarms that were designed to notify us of rapid deterioration. We actually may be able to do better. So I always love this quote from Einstein: doing the same thing over and over again and expecting a different result is basically the definition of insanity. And from Scott Peck, always trying to simplify everything, looking for formulas, easy answers, algorithms, SBAR. These easy answers are really important, but also what we want to understand and appreciate is the profound complexity of COVID-19. First of all, in its iteration, and second of all, in its projection. And therefore, it becomes much more difficult for us to develop models that work. And that's something we have to appreciate and understand. But I want to remind you about the similarities of hyperinflammation, COVID, and sepsis. And the similarity, particularly as it relates to COVID, which is one of the earliest signs of deterioration of patients who have mild to moderate and then moderate to severe. And that is respiratory compromise. Decompensating, rapid rate, normal SaO2, and then decompensating further to rapid or slow rates with a profound, severe decrease in SaO2 and a change in end-tidal CO2, correlated with effervescent temperature and compensatory heart rates. So very, very important. So again, moving from the external measures being rapid respiratory rate, end-tidal CO2, and SAT, to the internal measures, which are metabolic acidosis and the base deficit, correlating this importance and those similarities of hyperinflammation and COVID into a profile that you are going to evaluate, really critically and profoundly important. So I want to remind you that our goal is to keep mild patients home, to admit moderate COVID patients to the hospital, and monitoring moderate patients and protecting them from rapid deterioration to severe deterioration. And that as we look at deterioration in moderate COVID-19, we're going to just think about this little video. We're going to take a look at a rapid deterioration from moderate to severe as we inhale the virus and as the virus communicates into the pulmonary valve and it starts to cause massive changes in the lung parenchyma. And remember, our moderate patient may be mildly hypoxic, doesn't necessarily feel short of breath, has a rapid respiratory rate. But as they progress to severe hypoxia and to, again, they may have a very rapid respiratory rate or the respiratory rate may slow. They now start to develop right heart failure and they have profound hypoxemic hypoxia. And what we start to see is the exhalation of end-tidal CO2 goes down as they have failure of perfusion of the lung valve. This is a beautiful video. If you're interested in the video, I'm happy to send you the link, but I will just mention I'm going to leave the video now showing you the dyscrasia that's occurred. I want to just go backwards and just say, amazingly, if you go to this article, the link for the video is embedded in this article about the deterioration of COVID-19 patients and utilizing that information to help us understand it. So again, we just remember that at the bedside, we are focused, moderate, fever, sore throat, runny nose, patchy shadows on the chest x-ray, ground glass opacity on lung CT, to severe. Now your respiratory rate has become very tachypnic, your SAT is less than 93%, your P to F ratio less than 300 when you're at rest and with oxygen, and your chest x-ray has a 50% increase in lung opacity in the last 24 hours. Now, our goal is to evaluate you here and to protect you as best we can from the evolution to the severe deterioration state. And that is critically and profoundly important. So if you look at this article, which is just really beautiful, it's about, I think it's about 2,000 patients, might be a little less. Looking at patterns of deterioration, you can see that the number one pattern of deterioration COVID-19 was deteriorating to ARDS. And correlating with that, so when we look at the correlation factors, what we're going to see here are the big three, and actually almost the fourth as well, that the big three predictors for those patients was really related to respiratory rate, SAT, and to their PF ratio. And you can see in terms of prediction, look at how highly this predicts your moderate patient and how significant this predicts your severe patient. So this, of course, is looking at your internal respiration. This is serum lactate, and I would prefer we were looking at you and protecting you here rather than waiting until severe decompensation. Now, these are simple clinical signs, and the simple clinical signs for respiratory rate are, this is a strong and explicit forecaster. It predicts deterioration across the age continuum. Oh my God, it's the first sign of change, but we know time and time again, thousands of articles that talk about the importance of respiratory rate monitoring and our failure at the bedside to monitor the respiratory rate particularly. So that's one of the reasons I think that the early warning scale, both modified early warning scale, national early warning scale, the other modifications, hasn't really worked as well as it needs to for our patients with COVID-19 because respiratory rate has not been the major focus when we're talking about those patients. So we move and we say, okay, so now let's think about machine-based learning. And how do we develop machine-based learning and develop processes that are based on clinical information perception that allow us to malleate, I don't know if that's a real word, but to make it malleable to every situation, to our particular patient, to try to develop methodologies that will give us good prediction. So again, if we look at our clinical predictors, mild, moderate, severe, and critical, we're just going to remind ourselves that our focus at the bedside, when we're talking about our patients and what we really want to focus on that's straightforward and relatively simple, is tachypnea, hypoxia, and respiratory distress, as well as decreasing SaO2. Things that are simple, that we do everywhere, that we have the capability to utilize. So I remind you that we have technology everywhere we work, that what we want to do is build surveillance strategies, create meaningful event groups, predict what is going to happen for our patients, and build prediction models with parameters that alert practitioners, especially when we're really busy or when we're integrating less expert persons at the bedside. And the four big ones I'm concerned about with COVID, although heart rate is really important: temperature, SpO2, end-tidal CO2, and respiratory rate. So one of the things that I'm talking about here today is talking about advanced event surveillance, which is embedded in the IntelliView clinical decision support tool. You might be using other things, that's all okay, but today I'm just talking about advanced event surveillance and building my monitoring profile to embrace my patient, so that when an event that triggers 2 or 3 changes or all changes, that triggers an alarm. So it's not a single change, it's not a non-sustainable change, it's a fully customizable change that is going to embrace my patient and allow me to build a protocol. So first and foremost, a protocol to screen all patients for COVID-19, which will give me a subtle deterioration alarm, looking at, in particular here, heart rate, pulse ox, respiratory rate, and temperature, prompts all clinicians to come to the bedside and evaluate the patient more particularly. And then looking at a more integrated, in-depth model, which is worsening respiratory failure, and looking here using end-tidal CO2, change in respiratory rate, the reduction of SpO2 and increasing heart rate. These are going to be more valuable for those COVID-19 patients who are already on oxygen, who are deteriorating. Malleable, meaningful, specific, built to the clinical predictors of COVID-19. Now, in addition to that, I would advise everybody to have a COVID-19 laboratory protocol that actually embraces as much as possible inflammatory mediators and immunosuppression mediators, because that's going to give you a very significant profile that helps you to build your case for COVID-19. I love extra surveillance. I love Muse. I love modified Muse or News. But more importantly, I like a methodology that's patient and disease specific, that allows me to actually look at what I am worried about, in particular for heart failure, for COVID-19, for sepsis. Not one size fits all, but right size for the right process. And it gives extra eyes that never tire. And that allows me and facilitates my ability to move forward. So remember, COVID-19, complex, complex, complex. We're evolving every day, looking at RAS, the ACE2 receptor inhibitors, the role of immunosuppression versus hyperinflammation. Remember, in sepsis, it's hyperinflammation. But we believe now in COVID, it's immunosuppression, that you have hyperinflammation, but you also have immunosuppression. And that early recognition, which tells us about those patients who are at risk, looking back at simple clinical predictors, respiratory rate, SAT, heart rate, and moving those clinical predictors to early intervention strategies, looking at adoption of high flow oxygen in the mildly hypoxic patient to protect them, and then to look at whether or not they're responding, to restrict their fluids, to do proning. If you want to do chest physiotherapy, that's awesome. This is not a community-acquired pneumonia. So chest physiotherapy has not been shown to be beneficial or non-beneficial. And you've got the time and you've got the staff. Do it, do it, do it, do it. It's beautiful. It's wonderful. And it protects them from evolving pneumonia. But remember, it's not really a pneumonia. It's a viral disorder. Okay. So just want to be sure you understand. There's so much we don't know. And it looks like we're going to be forced to refine what it is we do know. The Delta variant, the next variant, and the variant after that, and the variant after that. Whether or not we have to have boosters, whether we're going to have another surge, maybe we're going to have another winter like we had this year, it's all possible. But what we want to do is protect our patients and ourselves from disaster. We want to identify patients early. We've got to build laboratory profiles to assist with diagnosis. We have to build profiles to alarm and capture meaningful data. We have to monitor respiratory rates effectively. We have to look at pulse oximetry effectively and continuously on patients at risk. And we have to stick with the process because we have to modify, and modify again. But thanks to all of you, we turned this horrible COVID-19 virus, we turned that around somewhat, and we all saw that as we learned, we created methodologies to help our patients survive. Thanks to you, it's working. And now on to the next step to make it work better, to make it work harder, and to give us better data so that we can protect our patients and provide strategic interventions at the right time for the right problem. I thank you so very, very, very much. And I'm now going to turn it back over to Angela. Thank you.
Thank you, Barbara. What a great, timely, and thought-provoking presentation. I would like to remind the audience how they can obtain their CEs for this activity as well. Continuing education for nurses and respiratory therapists. This has been approved for 1 contact hour. To obtain your CE credits, go to saxtesting.com/BO. You will need to register at the site and complete the evaluation, and upon successful completion, you will be able to print your certificate of completion. And we do once again want to thank Philips for this educational activity. An archive on-demand version will be available on better-outcomes.org. An email will be sent to all registrants when it is available. The on-demand version will be accredited for nurses and respiratory therapists. So now, Barbara, we are going to start with some questions that I have received. And my first question to you is, what treatment specific for COVID-19 would you initiate at the point of detecting the onset of sepsis and respiratory deterioration?
Okay, so I'm having a little bit of trouble to differentiate that. So, talking about onset of sepsis or onset of COVID? So let's talk first to what the question was, which was onset of sepsis, correct? Onset of sepsis.
Yes, I think so, they were specifying COVID-19.
I think they meant COVID.
I think so.
Yes. So onset of COVID, remember, onset of COVID is really mild COVID. So that's really onset of COVID. And when we look at mild COVID, we might have those individuals. Those individuals typically are not going to come to the hospital. They're going to manage themselves at home. They're going to basically just be made very aware about deterioration symptoms and why they need to come to the hospital. They need to aggressively control their temperature. They can do that with cool or lukewarm showers, Tylenol, Motrin every 3 hours. Take a day, then take some rest periods and start again, making sure that they're well hydrated. They have aggressive fluid resuscitation. I think also talking about vitamin D, vitamin C, other vitamins that are immune-enhancing vitamins. That's why vitamin C and vitamin D have been very helpful. And then within your local guidelines in the context of what you do for patients who are not in hospital with mild COVID. But in general, we don't do any aggressive medical therapy for patients with mild COVID. With moderate COVID, you're now preventing with some mild to moderate hypoxia. We're going to start to, typically with the nasal cannula, we're going to progress that to high flow oxygen. We're going to do self-proning, and you can do self-proning at home as well. Self-proning, you can add in chest physiotherapy. That's always a benefit. I'm not positive of the correlated benefit to COVID-19. And as you may or may not know, now the current literature is actually not positive whether proning is actually helpful in COVID-19 or not. But we're continuing with COVID until we're told not. Then we look at the initiation of methodologies like remdesivir, other anti-inflammatory and immune-enhancing agents. And we really have to look at those as the patient progresses. Once you are requiring intubation, now we're going to think about dexamethasone. We are going to think about other strategies. And by the way, I totally made a misnomer, so I want to go back to the patient with mild COVID. So the number one thing with mild to moderate COVID out of hospital, monoclonal antibodies. And so you want to be very aware that monoclonal antibodies are what are in general administered to walking, talking COVID-19 patients. That utilizing monoclonal antibodies for those patients is a really significant aspect and a move forward. So that's something else to really be considering when we're talking about mild to moderate. So I have a whole list of therapies. I just didn't have time to go through it, and I'm happy to send that list out. Is it okay for me to share my email or my phone here? I think it's probably okay. I'm going to do it anyway. So my email is BA.Mclean, and that's MCLEAN, at a very old address, Mind, MIND, Spring, SPRING.com. If you email me, I can send you the most up-to-date list. There's about 12 agents that are in test, have already been recommended or on EUA, and then about 20 that have been completely dropped from utilization. But a lot of times it depends on where you are, what your hospital has, what your PharmD is representing, and or what your PharmD is recommending, and what's available for you. But typically monoclonals for mild to moderate. When you're moderate, we're going to think about remdesivir, and as you move to severe, we're going to think about combination of anti-inflammatories and also, thank you very much. Also think about anti-inflammatories and immune enhancers. And remember, that's why vitamin C and vitamin D and thiamine and selenium have all been considered to be quite important in the COVID-19 patient. So all of you out there, vaccinated or not, get yourself on board with vitamin C, selenium, and thiamine to help boost your immune system, because that can be very helpful. Okay?
Awesome. And have you also, have you used Combivent? Has that been proven to be an effective treatment for COVID? That was another question.
We're not using it. So, but I can't tell you for absolute fact whether or not it's not in my list. So I think we do strategies that we try within our practice to improve, that we have some history with, that worked before. As you may know, lots of folks are trying HIV agents, Hep C agents, but again, a lot of the things that we try are based on our experience, not really based on science or evidence.
Okay. Yeah, for sure. And then one of the questions came up about what modalities were you using for CPT early on? You alluded to some chest physiotherapy, and is that something early on you encourage?
So let me just make sure that I appreciate what the audience is asking and what I perceive. So when I think about chest physiotherapy, I think about percussion and postural drainage. So early on in these patients, right, they've got this viral invasion. It's the viral invasion and the alteration, the barrier of the alveoli and the endothelium that is really the problem. So chest physiotherapy might help them to mobilize secretions, but secretions really aren't the problem. So what I was saying is chest physiotherapy is great. It's not contraindicated. It's great if you can do it. But I don't think overall that is a methodology that has been shown to be beneficial in protection from the evolution of the viral infiltration and then the shift in alveolar functionality. So, I would tell you that it might not be the top of my concern, but I think that if you're able to do it and your patient can sustain it and you can do it effectively, you certainly should.
Yeah, that's awesome. Thank you. And, just the last question here. Have you kind of found that you've had to hit the reset button at your hospital for the sepsis treatment plan for your patients? I know here at my institution, it seems that, we got really used to not giving as much fluid. So then with the patients who are truly septic and not COVID-19, I think sometimes we have to hit the reset button. Are you kind of having to do the same thing there?
So I really love this question. I know it's your question, Angela. So between Angela and myself, we are both very strong advocates for targeted endpoints in fluid resuscitation. So I think, unfortunately, the reset button is based on two things. The reset button is based on the fact that most of us don't have a target. We just give fluid, and we give fluid to the guidelines, which are 30 mLs per kg, given in a fluid challenge, which means as fast as possible. And what we've discovered for COVID and for sepsis is something that they share is this change in the endothelial barrier. And anybody who knows me knows that even if you heard me speaking about sepsis 8 years ago, I talked about it's an endothelial disorder. And it's the same thing with COVID. It's a loss of that endothelial barrier. So when you overstretch your vessels, you distend and you cause alterations in glycocalyx, which is just the barrier of the endothelium, which now propagates high hydrostatic pressure movement into the interstitium, which then causes compartment pressures and has a whole 9 yards of evolution. So I think the reset button is you need to reset from mean arterial pressure. Period, end of discussion. The same thing I've always said. Stop being so focused on mean arterial pressure because that will guide you to be doing more fluid resuscitation. Focus on a targeted endpoint. The targeted endpoint in your hospital might be stroke volume. If you wanted a dynamic endpoint, it might be stroke volume in response to volume. And you could also consider stroke volume variation, just assuring that you're doing it contextually in the correct way. But I think the reset is reset on mean arterial pressure and starting to focus on true measures of volume resuscitation. And that should change the way in which we're giving volume and also the way in which we use vasopressors. But that's complicated, and it's evolving science over the next few years. We'll all be seeing our science change in the next few years, and COVID made it happen faster. Hi. COVID made it happen faster. Someone came in the room. Sorry about that. Okay, very good.
Thank you so much, Barbara. Oh, my goodness, we could talk all day about all of your knowledge, so thank you so much, and I'm going to conclude the question and answer session, and I'm going to hand this over to Nikki.
Okay, thank you. This concludes our webinar for today. I would like to remind the audience there is a survey for you at the conclusion that will pop up immediately, and we will greatly appreciate you sharing your opinions on today's webinar. Thank you again on behalf of our presenters, Sachs Healthcare Communications, and our sponsor, Philips. I hope you enjoy the rest of your day.